Updates in Pediatrics for the Department of Pediatrics at Wayne State University School of Medicine. Today, in our community, we've noted, an increase in mental health diagnoses and difficulties many of our patients and families have dealt with. And even just prior to the pandemic, we were just wrapping our brains around trauma and adverse childhood experiences. We're very fortunate, though, within our practice at Wayne Pediatrics to have a clinical psychologist and staff that's been able to help us with our patients and in our families that are dealing with several difficulties just from day-to-day living, getting from one place to another, and just dealing with all of the feelings and emotions that they've been kept buried for several years in some cases. So our presenters today are Dr. Jameel Smith and Dr. Joy Claiborne. Dr. Smith is the lead clinical psychologist at Wayne Pediatrics. She received her doctorate of philosophy and school psychology from Michigan State University. Her undergraduate degree was in economics at the University of Michigan. And Dr. Joy Claiborne is a PhD candidate at Michigan State University in school psychology. And today the two of them are going to present on innovations in pediatric primary care integrated health. Thank you very much.
You're muted, Dr. Smith.
Thank you. Good morning, everyone. Happy to talk about this topic. It's very timely, no matter what station or publication you read. We're hearing more about how to support young people in their mental health. So we will go ahead and get started. So today, our hope is to review some of the latest understanding of integrated behavioral health and pediatric primary care, and then to sort of expand our conceptualization and understanding of what integrated behavioral health is, because we know that there are challenges and limitations to implementing integrated behavioral health and supporting young people right now. And then we want to increase our listeners' knowledge and tools for supporting all levels of need within integrated behavioral health, pediatric primary care. So I'd like for you as a clinician, as a practitioner, to just reflect on this idea. How comfortable are you implementing behavioral health care within your patient's clinic visit? One of the things I'd invite you to consider is, with the limitations that exist within the nature of primary care, and given various levels of training and experiences, how comfortable are you with your go-to strategies, with your go-to process for supporting behavioral health? And we hope that when you leave today, you find some new sort of, what do I do come Monday morning idea to increase your capacity to support young people. So when we talk about integrated behavioral health, what we're talking about is this idea of integrating the delivery of care for individuals that might have comorbid behavioral and general medical conditions. And so they're presenting with some medical concern, and there seems to be something also behavioral that is connected to what is happening. I love this visual, just demonstrating the overlap. We cannot get away from this idea that we can only focus on the physical needs of our patients. Everything is interwoven into just that human being experience. Others sort of talk about integrated behavioral health as an approach that allows for both behavioral health providers and physicians to collaborate and provide biopsychosocial treatment. So looking at the whole facet of the whole person, the whole child, to patients in one primary care setting. I love this visual here. Sometimes children and parents need someone to talk to. And now that someone is right here with integrated behavioral health, it's this idea of this one shop to deal with lots of different issues. And these are, some common things that overlap and present themselves with patients within primary care. So one of the things that we know, some of the literature talks about that some physicians, report feeling uncomfortable or lacking confidence managing behavioral health in children for various reasons. Some research in looking at residents, physicians talked about that they felt an increased need for competence and confidence in treating mental disorders. This idea, I'm weak in identifying and diagnosing psychiatric disorders. I need more training in that area. And then the realities of time, right? Some resident physicians talked about a desire, right? And recognizing the need to incorporate behavioral interventions, but it's difficult to do so with time constraints of those visits. I think it's an issue of time. I think it would be beneficial to learn behavioral interventions, but the way the clinic is structured, I don't really know how much more I'd be able to implement in an encounter. So those are very real realities around the challenges of integrating behavioral health. But one of the things I want us all to reorient ourselves to is this idea, the role of a pediatrician provides this unique avenue to addressing mental health concerns, because there's this idea of this primary care advantage, this developmental mindset that is brought to serving our patients within primary care. And it's at the front line of pediatric health care. And we know primary care pediatricians see patients longitudinally. So that really gives an opportunity to develop really long-lasting and trusting relationships that often can be therapeutic in nature with parents and families. Really allows to promote social emotional health. So leaning into this idea of prevention with every contact, regardless of whatever they're coming in for. It also allows us to prevent mental health problems by education and anticipatory guidance, and intervening in a timely way when we see those risks and concerns emerge. We can do something about it right then. And it's never become more apparent that these are the kinds of things we need to continue to think about and tinker with and grapple with and how to address, because, the pandemic certainly helped us to think about these things. Prior to the pandemic, we saw this increased psychological distress among young people in general. The Kaiser Family Foundation talked about adolescents with anxiety or depression, how it had increased over time. And then the Department of Health and Human Administration talked about, just thinking, how did a COVID related event, someone in the family got COVID, a child got COVID, someone at the school got COVID, or just experiencing how COVID was affecting lots of different people in our world and our social sphere. We saw that really impacted the way that young people began to develop these symptoms of mental health difficulties. And so what this graph, I think, shows is, a range of mental health challenges that cropped up once young people were either exposed to COVID or knew someone or were aware of a COVID challenge that was affecting someone that they knew. This idea that, this 12 to 17-year-old band, we saw that with anxiety and depression, this graph shows us that, a large percentage of adolescents struggled in those areas. And even with younger kids, 0 to 5 years old, behavior conduct disorder increases in those, the percentage of those individuals who were diagnosed with that. So, we know that the littles will often communicate through their behavior. And so in general, we know that the young people that are in our lives and in our world are increasingly needing support. And what we'll argue today is there are various ways and various levels that we can try to address that. Prior to the pandemic, only about 20 to 50%, of young people had access to a mental health professional. And then during the pandemic, that worsened. Certainly in pediatric primary care, we saw, how kids weren't coming in for their appointments. And so we also saw these declines in utilization with Medicaid and private insurance, pediatric beneficiaries with mental health. So, but there are many benefits to us continuing to work through some of the complications of having an integrated approach to behavioral health and pediatric primary care. The research is starting to reflect that there can be positive outcomes for patients and providers because, if prevention is done, if screening is done, then providers can feel more capable in supporting their families. Improvements in screening, identification, and intervention have occurred when there is an integrated behavioral health approach. Patients and caregivers are really satisfied when that is part of their care. Improvements in mental health outcomes, cost effectiveness, and reducing provider burnout, again, when individuals can be able to have this way of dealing with the whole child. So there are various ways that one can approach integrated behavioral health. There's this coordinated behavioral health model, a co-located behavioral health model, and then full integration. Coordinated behavioral health is where you might consult with psychiatry and refer out to a therapist within the community. Co-located is where you have a pediatric primary clinic, but then there's also a behavioral health clinic located in the same space, but there's not integration in terms of electronic medical records or teaming that occurs in terms of coordination. And then there's full integration where the physical and behavioral health services are provided in the same site. They're integrated, the notes, the records, and everything are all shared amongst the providers. We know that full integration is ideal because compared to a co-located model, we can see higher rates of guidance, adherence, more direct contact with schools. So coordinating services, more frequent observation during clinical encounters, when you can see what's happening and where the improvements might be occurring all in one visit, supporting, mild to moderate presentations, again, preventing some things before they exacerbate and become worse. And then there's, evidence-based that though this approach can improve outcomes and reduce costs in adult populations, we're still learning how this benefits our pediatric population. There's still limitations on our knowledge around how it is serving them. And so there's opportunity there for increasing our understanding. So for you, as an audience, one of the things to think about is, what if you need more training to support behavioral health? What does one do as a physician when there isn't a behavioral health clinician, integrated into the care or even available if they're integrated? What if there are constant waiting lists if you have a coordinated care model where you're referring, young people out into the community? What does one do when there is that gap in service? We know that there are challenges with training. We talked about this idea of lack of confidence, and then just, improving one's knowledge, even if you have that basic knowledge. Physicians who have, talked about this idea of role overload or burnout. They sort of, that affects their ability to think about whether it's really effective. is particularly when patients have those more intense concerns, and there are time constraints, space constraints, funding constraints. And then there's this issue of those severe complex cases. When we have patients who come here away in pediatrics who have been on a bevy of, psychotropic medications, they don't have them, they're not taking them. What does one do immediately to support that care or reinitiate that care? So there are challenges to approaching this, but we know that we have to continue to grapple with what to do. And so what we wanted to present today is just orient our thinking to this tiered support and care of integrated behavioral health. This isn't really a new conceptualization in the public health field. We see an approach to population health that deals with various levels of need. And this certainly is something that some researchers are starting to talk about in spaces where children are serviced, trying to figure out how to meet all the needs of our patients. That first tier is where we are thinking about preventative and universal care, screening and education. That second level is where we're noticing early signs and providing some brief intervention and skill building. And then we have that more intensive third tier where we're addressing psychiatric consultation, longer term psychotherapy, and referrals to our behavioral health partners. Just this last month, the American Psychological Association highlighted this trend that, as psychologists, and I would say, those of us in the healthcare field, we have to find innovative and new ways to reach more people and take a more population and health and preventative approach, because we can't just wait till we have an elevated screener to say, oh, maybe we should provide an intervention. We want to try to think about, what are the opportunities to support and build capacity in our children and families early. In the schools, another really important environment and system for young people, they too have this integration approach that is tiered, where you have interdisciplinary teaming around mental health, sort of prevention and promotion of wellness. At-risk students are targeted with skill building, and then there can be direct intervention to identified student needs through special education and other kind of programming. And even colleges and universities, right? Another setting where young people are often located and needing various levels of support. Colleges are saying, we can't rely on this model of our counseling services because we can't meet all of the need. Students need rapid access to care to be able to walk in same day, have intakes, have a single counseling session just to deal with their issues and be on their way, workshops to build education and capacity on some of those things we know that can prevent things from getting worse, like stress, sleep, and time management. And then this idea that even faculty members, as first responders, so even teachers, faculty members, even physicians, figuring out ways to recognize those early signs and be able to offer or triage, how to support young people. Less formal support groups connecting with wide ranging of resources. So everybody's thinking about, what are the different needs of young people and how can we tackle all those various levels of need. The American Association of Pediatrics supports this idea, a developmental approach to children's mental health that encompasses primary prevention through promoting social, emotional health and safety and nurturing relationships, secondary prevention through screening, identification, and assessment, and tertiary prevention through treatment and co-management with mental health professionals. So in pediatric primary care, one of the things we'd like to invite you to consider is, in that tiered 1 support where we're doing universal supports and prevention, screening is really important, having resources available. um, to young people. I just want to show, even other organizations and systems, CHOP, Children's Hospital of Philadelphia, also supports this tiered approach to supporting young people, to build capacity and care in supporting the mental health needs of young people. So with screening, we know that when we screen for anxiety and depression or general behavioral concerns, we can identify concerns and connect our young people to intervention or the family to intervention. It builds capacity, prevents worsening conditions. But we do know that the challenges, improved outcomes, we're still learning if that is substantiated fact for pediatrics. There is limited time. There's patient family literacy issues that may occur, reimbursement, which may not necessarily be much of an issue now, but results are not always addressed and may impede outcomes. So you might do the screening, but if you're not addressing some of those at-risk concerns to build capacity, then we're not helping our young people and our families before it escalates. And then, interesting, some research is showing how parents of younger children may not see value in completing screeners. We know that most of the concerns about mental health tend to nest within adolescence, because that's when, developmentally, those issues can really become pronounced. And so this is such an opportunity. If a younger child not necessarily is behaviorally acting out, but the small concerns about, making friends, for example, if that's something that can be folded into that visit to strengthen their social skills so it doesn't turn into something worse later, there's really potential there. With Tier 1, we are focused on resources at all points of entry. So thinking about education campaigns, chats where, clinicians make themselves available to answer large general questions. And then this idea of going into spaces where young people are located, collaborating with community partners, schools, finding and thinking about ways to go to where the need is and not just waiting for them to show up within primary care. Peer-to-peer programming is not a novel idea, but it is a way to think about building capacity at that universal level. It allows, in the schools, it has allowed students to be able to be agents of change for their peers, normalizing mental health concerns and building mental health literacy and getting that message from their peers, which we know developmentally can be very important. Awareness campaigns, what is anxiety, what is depression, what happens when you go see a therapist, how can you talk to your pediatrician about this? Just generally creating a culture of awareness. Researchers are talking about how these can really be powerful tools. Others in healthcare have taken this approach. CHOP has this lay therapy where they train, non-specialized clinicians to deliver a certain amount of care and response and support. The University of Michigan, they have this peer-to-peer program that they disseminated out into the schools, which helped to build awareness and literacy. And they found that youth really talked about being more confident in identifying signs within themselves and helping a peer access support, that they were more likely to seek help if they were experiencing signs themselves, and youth were really comfortable discussing mental health issues with peers. And so can you imagine in pediatric primary care if we had young people who might take on some of this information? Certainly training and supervision and guidance will be needed, but again, if we can prevent some of these things from exacerbating, that would be great. Just thinking about, I wanted to just share just some local data in terms of patients I've seen for psychotherapy. One of the things I want to highlight is this idea: traditional psychotherapy is not always needed, right? So even if you have a family or a patient that presents with some concerns, if there is a way to deal with and provide a strategy or an intervention or support within that moment, there's a lot that we can do that doesn't necessarily have to go to traditional psychotherapy. Research has shown that the modal number of sessions before termination in psychotherapy is just one. So that suggests that, referring to psychotherapy may not be the best, opportunity to get the most bang for our buck, so to speak. About 50% of children make small number of visits to providers when they're seeing a mental health clinician. And with local data, 0 to 3 visits was about a little over half of the percentage of patients I've seen. So this to me suggests that a tier 1 approach can be useful to reach the needs of many young people. Right, Joy?
Okay, thank you, Dr. Smith. So now we are shifting gears to talk about tier 2 level supports. And so when we talk about tier 2, we're focusing on this middle group here that really is the focus of a targeted at-risk response. And so at the tier 2 level, the purpose and function is really focusing on early identification and intervention. And really, when we're looking at this tier, we're looking to address the mental health concerns for those who have been identified through like the screenings that Dr. Smith mentioned, referrals or other teaming processes, for those that may be experiencing like mild stress, functional impairment, or just might be at risk for, particular problem or concern that they came into the clinic for. And so some examples that we're going to present today of tier 2 interventions are various apps that you could try out, websites with ready to go resources, skills groups, handouts, and resources. And so we're going to share on the next couple of slides some really great resources that we found that could be really helpful for you to integrate into a visit or just give referrals that a patient could use or a family could use soon after the visit. So this first website, or just this first block of resources that we're going to provide, are going to be focused on websites. So this is a website, a very easy to use website called Therapist Aid. And while it is primarily sort of focused on the audience being mental health professionals, there are a lot of really great ready to go resources on here that don't require as much background knowledge and training. So there's a lot of videos on here, worksheets, books, etc. And so we wanted to highlight one of those resources today. And I think something that's really good that you could use during the video is to look through some of these collection of videos that they already have that are very psychoeducational based that you could play during a session, or you could, refer to a patient or a family to kind of look at once they leave the session. So Dr. Smith is going to click on the website.
Can you see my screen?
Yeah.
One of the videos here that I thought was really neat is this idea of behavioral activation, which is really important when you have low mood. This video is about 4 minutes, and this could be something perhaps a physician might invite, if you had a device in the room, a patient to look while you leave and come back, and that kind of thing. But it's just another way. Video is a medium that we really understand a lot of information these days, especially young people. And if you could have both a parent and a young person to watch this, it might be helpful. I won't play all of it, but I'll just give you a glimpse.
The sound is really muffled, Dr. Smith, like you can hear it.
Okay. Okay. So I, won't make you chime in and listen, with your ear to the screen. But it's just when you think about what will help someone to learn, sometimes providing a handout may not necessarily work for the family or the child or the young person in front of you. So having a video ready to go could be helpful.
Okay, the next resource that we want to highlight is another free website called 7 Cups. So users are going to have to create a login to interact with the website, but it's very easy. You can do it within a couple of minutes. And they have a lot of resources on this website, such as like the self-help guide and other sort of resources that are free. The one feature that we wanted to highlight today, which is very, novel and innovative, is this free 24/7 chat that they have with a trained volunteer listener. And so again, the patient could log into this, or you could have a parent log in, for a child. And Dr. Smith is showing on the screen here what an example of what that chat room would look like. So yesterday, Dr. Smith and I logged in. You had to do a very short, just sort of screening question of what you're here for, what are your concerns. And within a couple of minutes, we were connected to a listener who responded very promptly to our messages. And I'm not so sure if you guys can see it, but like on the screen, we even told them that we needed to leave, and they inquired about when we get back on as a means of follow-up. And so this is a completely free resource that you could give your patients, during the visit, and have them connect to before leaving. Or like I said earlier, maybe perhaps you give it to a parent because they might want to just monitor and make sure that it's appropriate. But the parent could log in and make sure that the child is able to log in as well, and being able to talk to someone at any time of the day. They have people ready to listen for a range of different concerns. Okay, the next sort of website or intervention that we would like to highlight is called a single session intervention, and there are a couple of them here. And so when we talk about single session interventions, these are very specific structured programs that, just intentionally involve one visit or an encounter with the clinic provider or program, and they're typically brief, less than 60 minutes. A lot of them that are on this website are between that 30 to 40-minute range, so very, very brief, but they have a lot of evidence, behind them as being pretty effective. And so the particular SSI resource that we want to highlight today was developed by Dr. Jessica Schleider. She is a psychologist at Stony Brook University. And so this is her research lab website, which is called Scalable Mental Health. The mission of her lab is to design and test and disseminate brief barrier-free interventions to reduce mental health problems at scale. So a really great website. It has a lot of great resources beyond just this SSI. If this is something that you think you're interested in, I think you should just go and explore the website, because she has a lot of papers on here and a lot of just different interventions and cool research going on at the time. So again, this is a free resource. It's research-based that can be easily utilized by physicians during visits or as a resource to inform parents or patients about to utilize post-visit. And so right here on the left screen, I just wanted to highlight some of the research that talks about the effectiveness of these single session interventions. And so the blue bar highlights the effects of a single session intervention, and the red bar are the average effects of a full length intervention. And so as you see here, what this is showing us, and this is from a meta-analysis that they conducted of 50 RCTs of single session interventions versus full length interventions. What you're seeing here is that single session interventions work. And in some cases, they work a little bit better than long-term therapies for a variety of different issues. And so there is power in delivering a single session intervention, particularly in light of the stats that, Dr. Smith presented earlier about children only coming to a small amount of visits, somewhere between that 0 to 3 range, or stop coming after the first one. Just thinking about the utility of an SSI, it really has a potential to capture the mental health needs of someone who's likely to not commit to longer term treatment, or for various sort of barriers or reasons, not just be able to come past one visit. And so the idea with single session interventions is like, what support can we provide now while they're in front of us or soon after, because we're not sure if they're going to come back. And so there are a couple of SSIs that can be found on the website. The three on the right screen here are a group of projects called Project Yes, but each one, like each little circle, is a different SSI for teens. The age that they have that's recommended for these single session interventions is between 11 and 17, and they broadly just kind of deal with learning new ways to deal with stress and helping others to do the same. So really focusing on internalizing and externalizing behaviors will really be appropriate for recommending such interventions. This is a screenshot from the website. And so, if you would go onto the website, you would just click the tab for Project Yes, and you would see this page pop up. And the purple bars at the top are actually different languages that the intervention can be accessed in. So again, just a really great resource that's free and research-based. This is another screenshot from another SSI on the same page, but this one is targeting parents who have difficulty accommodating children, their children's anxious behaviors. And so again, a really great resource that you could give to a lot of your families who are just struggling with having anxious kids and not really knowing how to support their anxious behaviors. It's very brief. It's a 20-minute intervention. And so this is just another resource that you could give families that are dealing with, just having difficulty accommodating behaviors. So there's a quick video on just explaining the intervention a little bit, and we'll play maybe a snippet of it.
Oh, that's true. The sound isn't good.
Okay. Yeah, so it just goes through, it's like a 2.5-minute video, and it just goes through what the purpose of the intervention is, who is likely to be a great, sort of targeted recipient for the intervention, and just talking about why it's so difficult for parents or just the purpose of the intervention is really to teach parents skills on how to help support their kids that are showing anxious behaviors. And so it just talks about why that could be really difficult for parents. So yeah, if you have time, I suggest that you go and check the video out, check out all the resources. And then, like I said, there's a bunch of studies on there. All of her work is open access. And so it's just, again, like I said, a really, really great resource to have just handy.
One of the reasons why we included this is because if you imagine yourself in front of a family or a child with, for example, some anxiety, you could invite that parent to watch this right after the visit and engage with the tools to get that single session information. So it's just a way to address the need right away. What I really liked about this video, and if you have a chance to look at it, is oftentimes parents who have anxious children will reinforce avoidance. And that video in particular kind of gives them some strategies to work against that reinforcement of avoidance, because you want to protect the child, and it's counterintuitive to say to your child, well, let's give it a try anyway. So I really like that.
So the next sort of bucket of resources that we want to talk about, technological-based resources, are mental health apps. And so as you all just know that interest in apps are growing. We all have them on our phones, but these mental health apps are becoming increasingly popular, particularly amongst adolescents. And so while these are really great tools to access, to aid just in access to mental health supports, the sort of downside right now is that we just really don't know a whole lot about some of them from a research standpoint. But as a professional who is dealing with adolescents, who are dealing with families in which they're likely to be utilizing these apps, or a parent wants a recommendation about an app, we have to start to think about, okay, even though that there's limited sort of research evidence base out there, how can we just, as a professional, best offer safe recommendations? And so to assist in this, the American Psychiatric Association developed a framework called the app evaluation model that I have highlighted here. And they just recommend in this framework that you take a very risk-based and personalized assessment approach to this. And you do that in utilizing some of the questions here. And so perhaps a family comes to you and they want to know just your recommendation on using a particular app, or maybe you want to look at an app and you want to sort of do your own review and provide a recommendation to families so that you feel comfortable with recommending certain apps. And so some questions that they highlight that we should think about if we're going to recommend an app to a family or to a patient are sort of these questions here. And so the first question that they sort of invite you to consider is this first one: is the developer of the app reputable? Does the app have a privacy policy? Does the app sell patient data or share it with others? Is patient data kept secure and private? Is there any evidence that the app is effective? Is there anything dangerous or concerning about the app? Will my patients be able to stick with this app? Is it easy and engaging to use? And then the last one: how does this app share data with the patient and clinical care team? So this is just one approach you could use. But we also wanted to highlight another approach out there. And so this is another tool that can help you to evaluate and provide recommendations to your patients about mental health apps, and it's called Cyber Guide. And so again, it's another website, and this website compiles apps by concerns and then provides a review of the app, which was conducted by a professional. So Dr. Smith is going to click onto the website here just to show you very quickly what the website will look like. So again, you see the concerns up here, like are stress and anxiety holding you down? There's some concerns up here. And then you can go in and review certain apps. So if Headspace, for example, you can click on that, professional review available, and it gives you the pros and cons. It tells you about this particular professional who reviewed the app, so you can see this is a person that has a PhD. And then there's a lot of information just talking about generally just the description of the product, who the audience, the preferred audience should be, all the way through cost and just research effectiveness. Scientific basis. And so a lot of really great information on this website. So again, another resource that you can use to review apps for yourself before you would like to provide that recommendation to families. Another resource that we wanted to highlight is a local resource. So similar in ways to things that we have provided already, but also different. So this is called My DW IHN, which is the Detroit Wayne Integrated Health Network. And so this is a local-based app that might be helpful to recommend to your patients. And it just provides resources and connections to mental health supports in the area. And so again, something that might be more locally based that could connect families and patients to community resources within their particular area, and just general supports as well. So just another sort of tool that you can have in your toolkit.
Finally, we have like this more intensive third tier for those more significant concerns. So one innovation that has proliferated nationwide is, a resource for our most impacted patients when we're needing or in need of psychiatry and psychological consultation. The Pediatric Mental Health Care Access Network will, sort of list for physicians ways to connect within your state to a organization or an entity where you can call with your concerns about the presenting concerns about your patient and get some psychiatry or psychological intervention in case that is not a part of the clinical practice. So in Michigan, we have MC3, which offers psychiatry support to primary care providers. I know some of our physicians have accessed this. And this includes support for children, adolescents, young adults through age 26, women contemplating pregnancy, pregnant or postpartum. Psychiatrists are available, same-day consultation, diagnostic questions. They provide medication recommendations and information about appropriate psychotherapy. And, it's just another one of those tools when there's finding a psychiatrist is like finding a needle in a haystack to support many of our patients. So, this is what the website looks like. And some of our physicians I know have utilized this resource. Some of their data that they report, they've enrolled over 3,000 providers, responded to 38,000 requests, helped about 16,000 patients. There's a similar model in Massachusetts, and their research found it improved access to psychiatry, child psychiatry, and it met the needs of psychiatric patients. And practitioners found that the consultations were helpful. This other idea to consider, some of the literature has pointed to within primary care, this idea of group or peer supervision, where a psychologist or even another mental health professional is available for case consultation and support to build capacity within primary care physicians' overall skill set. It could even be as structured as group processing to talk about mental health needs, or as unstructured as just like you might have a warm handoff with a behavioral health clinician. Hey, I saw this patient. This was the concern. I provided this intervention. These were my reflections about it. I wonder if, I might have considered other things, or I'm not real comfortable with motivational interviewing, and wouldn't that be nice if you had a professional who you could work on some of that skill building with, or talk through how that went with a patient. These are all ways, again, to build capacity within your own practice. Again, 7 Cups, they have online therapy. Online therapy is proliferating out there. It's at a cost, but again, when you're thinking about if there's a family who can access it and has the means, it's a resource and a suggestion for them. So we have a few minutes left. Joy?
I am muted, sorry about that. So we wanted to conclude our presentation today with a case presentation. And hopefully we will have some time for discussion after I present this case. So our case is that David and his mother are at the office today for an annual checkup. David is a 10-year-old male. He lives with his mother, father, and a 17-month-old brother. He's in the 5th grade and he has not been assessed for any outside services. He's recently experienced some disruption as his previous school closed suddenly, and he was then cared for by his grandmother for several weeks before transitioning to his current school. School is struggling to address his behavioral outbursts, which seem to occur daily and have involved physical aggression. The school has reported that he was very aggressive with peers and staff and had a very difficult time transitioning from activity to activity. So David is in your office, and because of this, the concerns that they bring to the visit today, you decide to give a screener, or you check his screener. And so this is the PhD 17. And you score it, and the scores come back that his internalizing score was a 3. The cutoff for that is a 5. His attention score was a 3. The cutoff for that one was a 7. And the externalizing score was a 7, and the cutoff is for a 7. You can also see just what the screener looks like here on the right side. So just looking at particular behaviors, looking to see if there are check marks within the never column, the sometimes column, or the often column. And so we have, about 9 minutes left before we conclude today. Just wondering what you would do as a physician if David was, presenting with these concerns and had this screener. What would your next steps be based upon the conversation that we had today? So we'd like to invite those to share if they would like to. If you want to write something in the chat, you are welcome to do that as well.
muted too, sorry.
Oh, sorry. This is Sharon. I would want more history, whether he was having problems in the first school, and then how was the time with his grandmother? Was that traumatic? Did anything happen? Or whether this was new, because he hasn't been assessed before, so I was just wondering. Get some more information from the family.
Okay. I think that, that in and of itself is a tool because, that's part of that problem solving model is sort of getting the specifics of how intense or significant the issues are. If we were to say, this is all new.
Yes.
This is all new and the grandmother, there wasn't particular trauma with the grandmother. What might be next steps? Well, I guess I would say that, a lot of times, and I've seen this happen many times with my colleagues, you lean into things that you have seen work with your own children, with your own experiences, or even with, past patients. But thinking about school consultation or, you know, trying to ask the family what they tried and if it has worked. And sometimes it could be, teaching them how to identify a feeling, going to that website that we showed, for example, the therapist aid, showing a video about, anger, or showing a video about to the parent about some parenting strategies. These are all kinds of things that you could suggest, invite the parents to look at. Joy, you have any other ideas?
No, I agree with the ones that you gave. I think whatever, and this is just highlighting what the things that we talked about in our presentation today, really just maximizing the time that you have with the family and the patient in the visit that you have now, considering that, like we talked about, it may be unlikely that we may see this family again, or you may see the family again, but in terms of mental health professionals, we may not see, that family, or we may not get a referral for the family. And so just whatever resources you can provide, during the visit, that therapist aid website, they have a lot of great handouts for psychoeducation for families that you can print out and give to families. We actually have a resource as well. And I know someone asked about us compiling a list that we can send out. That's an Excel sheet that just have just very quick links that you can click on to print out resources. So perhaps giving a particular handout to the family of just how to help the child with the behaviors that they're presenting could be really helpful. Or perhaps, you can ask the child to check out one of those SSIs that we talked about as well, one of the single session interventions.
So we want to leave you with, let's, lean into recognizing and responding. I saw a video recently that said the kids are not all right, but I would add, we can do something about it. And if you can think of one strategy that might be your go-to, that you might add to your practice, that is easy enough for you to do, feasible enough for you to do, then that is one way that we can continue to build our capacity and respond to the various needs of the young people that we care for. Other than that, any questions that the group might have?
I have a question, Dr. Smith.
Yes.
When you're talking about apps, I know there's a growing concern about confidentiality and data keeping. What are your thoughts about that?
I think that's a very real concern. And that's why, inviting parents to kind of do a little of investigation around that is important. The reality is particularly as you get with older kids who have access to all the technology and devices, they're sharing information anyway. The devices themselves are designed to track our behaviors. And there's so many, I mean, if I meet another young person who says, well, I saw on TikTok, ... So they are, using that information. But I say in general, when you have a parent in front of you, really trying to encourage them to increase their own digital literacy, investigating, sharing information, what is the app saying it's doing and not doing, and looking at their kids' devices to see what it is they're checking out. So.
Can I add to that too? That resource that we provided, they talk about that. That's actually something that was in one of the reviews of talking about data sharing. So that's something that you can look at too if you're interested about a particular app. If there's enough information about it, it will be on that website that we talked about earlier, so that you can evaluate it, for yourself as a parent.
Thank you.
Am I being heard? Oh, yes, okay. I just want to say, in the example that you guys gave, the 10-year-old, I mean, that family seems like they would be appropriate for the little app with the little nervous child, the little hedgehog.
Yes.
I mean, the family's coming in asking for ways to help an intervention, and I think that's great. I think for older adolescents, it's hard. I mean, parents often have, like you said, the digital, they don't feel comfortable if you hand them this. I mean, they'll just say, well, my kid can read it. And it's hard to get them to really engage in doing an intervention. I think that it's great that if we had some things that we could just offer, like a tablet in the room for adolescents to say, like, if you want some help, or you have interest about or questions about anxiety, you may want to look at this. Or I think that would be great, because oftentimes, the parents and the adolescents may not see eye to eye about the intervention, but just having that available, because I know we always screen and we ask, and a lot of kids volunteer, but I think, like, we just have the condoms in the room and then people just take them. Having something in the room that says, you can push on this, would you like to hear about this today, might be a good idea. But
Yes.
I love the presentation, it was great.
Yes, I agree. Thank you. I think that would be very helpful. Deal with it right there in the room. Okay.
Are there
thank you
any
so
other
much.
questions from our present? Okay, thank you very much, Dr. Smith and Joy Claiborne. We really appreciated everything. Was very well informative, and I think we can take a lot of the information that you gave and apply to our practices. Everybody, Jen Brandt will post the code for today's lecture so that you can receive your CME credit. Thank you very much for attending, and have a great day.